Hello, and welcome back. In chapter 20, we're talking about inpatient and outpatient addiction treatment. As the field of addiction continues to rely upon evidence based interventions, clients can benefit from inpatient services, outpatient services, or a combination of both, right? Immediate and long term needs are considered in determining treatment options for a variety of possible interventions. I currently play a role in consulting and directing a inpatient and outpatient substance abuse treatment facility. And again, the way we actually determine the level of care, our treatment planning, the settings itself, the services itself that go along with both inpatient versus outpatient settings, and the continuum that the client travels down or whatnot as they go through the recovery process can be very, very beneficial to long-term recovery. So when we talk about levels of care, inpatient treatment refers to treatment within a residential setting, whereby a client resides in a facility for a specific period of time. In inpatient settings and residential treatment, these are clients that need to have 24-hour supervision or monitoring because their relapse potential is so high, their withdrawal potential is so high. They're having medical ailments along with mental health ailments and whatnot that make them a danger to themselves, and they need 24 hours of supervision, right? A continuum of care refers to a treatment system by which the client enters treatment at a level appropriate for his or her or needs or whatnot, and then travels down the continuum in their journey to recovery. So SAMHSA is CAMHSA categorizes levels of care into the classification system consisting of basic, intermediate, advanced, and fully integrated treatment approaches. The levels of care. The intermediate level addresses two disorders but focuses on a primary disorder. The advanced level provides services for both disorders in an integrated manner. A fully integrated program provides treatment for multiple disorders by the same clinicians trained in multiple treatment strategies as is primarily intended for comorbid use disorders. So levels of care. We talked about ASAM, the Addiction Society of American Medicine. I'm sorry, the American Society of Addiction Medicine has a placement criteria. It consists of 5 levels of care. Levels of care are organized by the degree to which medical management, structure, security, and treatment intensity are required. So matching the appropriate treatment to each client that occurs at 3 levels: admission, continued stay, and discharge. So assessment dimensions. The problem areas identified ASAM are referred to as assessment dimensions, which include criterion, levels of care, and treatment modality that can be used when creating an ITP. The 5 levels of ASAM care and early intervention, outpatient treatment, intensive outpatient, or partial hospitalization, residential inpatient, and medically managed inpatient care. So ASAM dimensions. This is the 3rd edition. You guys are currently in schooling during a time where we are on a switch from 3rd edition to 4th edition, and currently our current textbook talks about the 3rd edition. But I'm going to give you some information about 3rd and 4th edition in this lecture. So in the 3rd edition, the 6 ASAM criteria are acute intoxication or withdrawal potential. That's how much withdrawal or intoxication, the behaviors that go along with the intoxication, the severity of the intoxication and withdrawal. Dimension 2 would be biomedical conditions, which talks about the client's medical or physiological ailments. Dimension 3 is going to be emotional, behavioral, and cognitive conditions and complications. Dimension 4 is going to be readiness to change, right? Relapse potential, continued use, or continued problem potential is dimension 5, which is a really important dimension because then it talks about the client's level of relapse and how often have they relapsed, what are the behaviors when they relapse, have they had multiple treatment episodes. In the recovery environment, their living environment, are they homeless, do they have housing, do they have support systems, do they live around their drug dealer, do they have partners or family members that are in active use. Those things can paint a picture for the client's clinical picture to let us know which level of care they should be in, right? Now, when we look at 3rd edition versus 4th edition, right? And again, the text is changing or whatnot. You can see that I just gave you 3rd dimension. You can see that there's definitely some changes. Dimension 1 is very similar to in 4th edition to 3rd edition with intoxication, withdrawal, and addiction medications. 2 is still biomedical conditions. 3 are still psychiatric and cognitive conditions. 4, now this is where we get the change at. The readiness to change ASAM criteria has moved out of the way, and now number 4 is substance use related risk, right? Which kind of is now it used to be dimension 5 in third edition. It's now dimension 4 in our current edition. In our dimension 6 in our third edition, it's now dimension 5 in our new edition, right? Which is recovery environment interactions. And then the very new dimension for ASAM is person-centered consideration. This is pretty much a summary of dimensions 1 through 5 based on the clinician's subjective view or whatnot, and conceptualizing the client's complete clinical picture. So, assessment dimensions. There are 4 ASAM treatment modalities: clinically managed low intensity residential treatment, clinically managed medium intensity residential treatment, clinically managed high intensity residential treatment, and finally, medically monitored inpatient treatment. Here, I wanted to show you guys, again, you're not going to find this on your PowerPoint, as I've added this to this PowerPoint or whatnot. This is the 4th edition continuum of care. And like you said, dimension level 4 is medically managed intensive patient. 3.7 level of care is medically monitored intensive residential services. 3.5 is clinically managed high intensity. And 3.1 is clinically managed low intensity residential, right? But you're also going to see below the threes or whatnot, you go into level 2, where you go 2.7, which is medically monitored intensive outpatient. You have 2.5, high intensity outpatient, which used to be PHP. You have 2.1, intensive outpatient. And then level 1, you have medically monitored outpatient. 1.5 is outpatient therapy. 1.0 is long-term remission. And 0.5 is early intervention. So, assessment dimensions. The goal is to assess clients within each dimension in an independent basis and to assess based on how one dimension might relate to another dimension. So the first level is 0.5, early intervention level. The intervention services are provided for clients at risk, those who might have had a substance abuse related problem. The next level is level 1, is outpatient treatment. It consists of a non-residential services which are organized. It can be delivered in a variety of different settings. Level 2 is the intensive outpatient treatment. This is usually an outpatient setting, can be delivered before, after work, or in school during week or weekdays. Level 3 is residential inpatient setting. It's a 24-hour residential setting in which services are provided by mental health professionals and addictive counselors. And level 4, medically managed intensive patient treatment. It's designed to provide 24 hours of medically managed evaluation. Clients at this level are often diagnosed with substance use and mental health related issues. So types of inpatient services. According to SAMHSA, some clients require only detoxification, while others might require detoxification with inpatient treatment. You have ambulatory detox, which is extended on-site. Monitoring is level 2 D classification, meaning that the client is not at this moment in need of inpatient services. The next level of detoxification, which are levels 3 and level 4, and require inpatient treatment settings. Clinically managed residential detox is a level 3.2D, where a client may be experiencing moderate symptoms of withdrawal, requiring all-day support. Level 3.7D, this is medically monitored inpatient detox. A client is experiencing withdrawal symptoms that are severe and requires 24-hour nursing aid and periodic visits from a physician. The final classification of detox is level 4D. Medically managed inpatient detox is the client is experiencing severe withdrawal symptoms and possibly unstable medical conditions. Types of inpatient services. You have 3.1, clinically managed low intensity residential. This client receives a structured treatment by clinically trained personnel at a minimum of 5 hours of individual or group sessions per week. Level 3.3, clinically managed medium intensity residential treatment consists of 24 hours of unstructured care and trained counseling professionals. The highest level is 4, medically managed intensive inpatient treatment is a program whose requires daily physician care, 24 hours of nursing care, counseling care for those who experience unstable issues with detox and substance abuse. Bernstein and Frio, posited that an approach that could be used by hospital emergency departments in care of patients with substance abuse and behavioral disorders. Right. The author suggested an approach known as screening, brief intervention, and a referral to treatment. The three-step, I'm calling it SBIRT, approach typically takes between 5 and 10 minutes, beginning with a brief screening and instrument and questionnaire. For moderate to high risk assessment, referral to inpatient or outpatient setting may be the result. The clinician most likely will conduct a biopsychosocial intake and obtain client release to talk to members of the family or members of the client support network. The use of motivational interviewing to assess readiness to change. MI can be used to identify in the identification of motivation to change and rehabilitation of a person's with substance abuse disorders and can be helpful in making decisions related to the required level of care. MI is directive, person-centered approach that has been shown to be effective in enhancing intrinsic motivation. Remember, with motivational interviewing, we're not thinking the client has an addiction. We're thinking that this client is ambivalent to change, right? And we want to invoke change talk to help the client actually get to their intrinsic motivation for change. Challenges facing rehabilitation centers. Many states have mandated insurance companies to increase and add coverage for addiction treatment. Those who are still individuals who remain underinsured and uninsured. Increased funding for treatment has contributed to an increase in inpatient centers and localities. Many individuals continue to have no coverage for addiction-related disorders. Client inpatient experience. And client inpatient experience might vary based on the level of care and whether administered in a public or private sector. A typical inpatient program is 28 days in length. In some cases, the program might be longer if detox is required. The program can also be shorter with transfer to intensive outpatient programming. And many public programs are generic in nature, meaning that they are not tailored specific to the individual's needs. So private inpatient programs can generally range from 30 to 90 days, depending on the level of required by the clients. A referring clinician's role is to often limited why client is in patient therapy. A clinician might be asked by an agent to share any significant case notes, which can be beneficial for treatment. After an inpatient referral, clients may experience feeling of loss, lonely, or sometimes depressed. Right? Clients are encouraged to reconnect with their clinicians to reschedule regularly counseling sessions. They're encouraged to discuss their recovery programs with their families and employers. They should not be too quick to jump back into family routines and employment, as again they're starting their stages of referral. Types of outpatient drug treatment. There are generally three types of outpatient treatment options. The first characterizes by continuing care. The second classification of outpatient treatment is known as intensive outpatient treatment (IOP). The third is the most intensive type of outpatient programs known as day programs. Day programs are more structured programs whereby the client makes a commitment to attend program between 5 and 7 days per week, where sessions may run between 4 and 8 hours a day. So drug and alcohol legislation affecting treatment. So decades, the policies of alcohol and drug treatment, abolition, and or control in the United States have been dictated by political ideology and governmental policy. Currently, the accepted practice for treatment of drug and alcohol is used for dependence and abstinence. From the Anti-Drug Abuse Act of 1986 beyond, minimum sentence for the distribution of cocaine and crack were mandated, resulting in higher incarceration rates. So rehabilitation versus incarceration. The United States has continued to have one of the highest, or not the highest, incarceration rate in the world, and felons lose a lot of rights after incarceration, including the right to vote, carry firearms, or the right to apply for Medicaid. The Federal Bureau of Prisons have many treatment programs for inmates with substance abuse-related disorders. Non-residential drug use treatment consists of 12 weeks of cognitive behavioral group program for inmates who have short sentences. Residential drug and alcohol programs use cognitive behavioral therapy as the primary approach. And currently, there are more than 3,100 drug courts in the United States. The first drug court programs were instituted in 1989.